بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على خير خلق الله سيدنا محمد وعلى آله وصحبه وسلم. I will address in the next 25 minutes the TB and HIV. It's a real problem worldwide as well as locally. We will address the epidemiology of the two diseases together. In fact, the two diseases are synergistic, and we will talk about the guidelines for treatment of co-infected patients and then the conclusions. The epidemiology, tuberculosis is the leading cause of death from an infectious disease worldwide. And in fact, it is the, I don't know how to get that over. It's, HIV and TB co-infection cause severe disease more than each one alone. The TB in the 2016 was among the top 10 killers for humans, ranking number 9. And if you look at the combination of the two, there were nearly 500,000 people who lost their life because of TB and HIV. In 2017, little improvement because the TB becomes number 13 and HIV is 14. However, in the low-income countries, the malaria, tuberculosis, and HIV remain clearly in the top 10 of the disease that can kill humans. There are some countries that have suffered the tuberculosis more than others. And if you look at the dark green colors, we're talking about countries that have an incidence of more than 500 per 100,000 per year. And anything more than 200 is really very high rate. And if you look at the disease countries that have more HIV and tuberculosis, it is now different distribution, because you will see the East Europe as well as the Sub-Saharan Africa as the two important sectors or regions that have the problems. With all the improvement that we have in mortality and HIV since 2005, with a clear reduction with the people dying from HIV in the last 20 years, due to the very effective antiretroviral therapy, TB remains a problem. As we talk, there are nearly 1,000 people who lost their life every day from a tuberculosis among the HIV patients. So what about our local data here? I've come across this article that talk about the incidence of HIV among the tuberculosis patients. It is around 2.5%. However, in the look at the mortalities, the mortality among the Saudi natives was at 21%, and among the expat was very high, almost double this rate. And I attribute that really to the very late presentation of both HIV and tuberculosis among this community. TB is also the main cause of admission in HIV patients, whether they are pediatric or an adult age, ranking around 30% of the cause of admission. In fact, it is the risk of developing an active tuberculosis is something between 16 and 27%. Sorry, 16 and 27 times more than the HIV negative populations. Any outcome you look at tuberculosis, it is worse when you have an HIV positive patient than negative patients. If you look at the cure, it is less with HIV positive patients. Mortality is high, retention of care is lower. So in fact, when they look at this article from Argentina, it is clearly stated that only 50% of those who have tuberculosis and HIV have cured the disease. There are 1 in 4 who died of the infection, in correspondence to 1 in 25 of those who doesn't have an HIV. So clearly, HIV is a risk factor for any bad outcome from the tuberculosis infection. The data locally is also there, and when we talk about the incidence of around 10% among the HIV populations who have tuberculosis, the outcome of those patients are worse. The outcome, be it because of treatment success, is less. Those who died with the co-infection are higher, and those even who lost care was also higher among the patients with HIV and tuberculosis. So a third problem that we have with the TB and HIV is that now we are having the multidrug-resistant tuberculosis and even the banned drug or XDR tuberculosis. And they are mainly on the Eastern European countries. And these countries, if you look really at the outbreak look at the disease distribution worldwide, we can see that the Southeast Asia harbor nearly 45% of the total populations who have tuberculosis infections. When you look at the co-infections, TB and HIV, it is mainly an African disease, with sub-Saharan being the highest risk. But if you look at the MDR tuberculosis and the XDR TB, although Eastern Europe contribute only for 4% of the total burden of TB worldwide, but they are contributing to 60% of those who have an XDR. And that is really very alarming, because you look at the data from Russia, the co-infections together, HIV and tuberculosis, are really increasing over the past 5 years, and they are approaching nearly 1 in 5 patients with B co-infections. The biggest problem is reactivation of TB in an HIV patients. This is the data from Saudi Arabia by Dr. Hanan Balkhi. She's looking at the prevalence of a latent mycobacterium tuberculosis in the kingdom. She did it by skin test with a BBD skin test, as well as with a quantiferon test, and almost the two figures ranging for around 10% of our population are having a latent tuberculosis. And what we know, that if a latent TB in a normal person, the primary infections would occur, early progression would happen in only 5%, and 95% will go to latent tuberculosis. But then the late progression to active tuberculosis will happen in something like 5 to 10% of a time in the lifetime of a person. If you compare them with an HIV positive patient, they have a higher rate of early progression to an active disease that may be double than the normal. And also, the main worry would be is the late progression from a latent tuberculosis that rank around 10% per year. And if you look at that, a year of HIV with latent tuberculosis is equal to a lifetime risk of somebody with HIV negative and TB. WHO recognized the risk, and I think they put on the prevention item, they put few facts. One of them, the people living with HIV are far more vulnerable to TB infection. That's true. And also the TB can be prevented if we institute the TB preventive therapy. However, only 1/3 of those who needed the treatment did an access to it in 2017. And more worse, we have 49% of the population with HIV who are estimated to have tuberculosis that don't know about their status of TB. So that's a really big problem. 20 times risk of HIV positive patients to do an active tuberculosis than non-HIV. And as I said, 50% doesn't know about their status. 1/3 of the patients with co-infection died, making the tuberculosis the leading cause of death in an HIV positive population in 2017. So what was the response? Everybody with tuberculosis has to be tested for HIV. The test is very simple, and yet only 60% of people get tested. And looking at our Ministry of Health data, there is probably 71% only get tested. So we really have to improve into this statistic. It's very easy to be done. What about the routine testing of TB in all our HIV patients? Again, the test here is difficult. It's not as easy as HIV tests in TB patients, but there was 8% of the patients living with HIV have been detected to have a tuberculosis in 2017 among 92 countries. So what was the action? It's very simple, 3 I's. 1, intensify the case finding for tuberculosis among HIV patients, treat them with isoniazid, and do an infection control. Diagnosing an HIV with tuberculosis is another dilemma, because the presentations of tuberculosis among HIV patients is not typical. And even the symptoms will be masked by the HIV itself. By the severe immunosuppression will lead the patients less likely to be symptomatic from his tuberculosis. And maybe the first time he will develop symptoms after you initiate the antiretroviral therapy as part of IRS manifestations. The X-ray is not typical. You may need to go for high-resolution CT scan. If you see a finding, it could be pneumocystis, it could be mycobacterium other than tuberculosis. If you look at the percentage of extrapulmonary, it's certainly higher. And if you look at the test that you need to do, we need to do an acid-fast bacillus smear and culture. PCR technology is not available everywhere, though hopefully the gene expert is available now in majority of centers that do care of HIV patients. And the extrapulmonary is really alarming. You see TB in an area we don't expect to have TB and with HIV positive patients. The combination of the gene expert and LAM provide the best hope for really diagnosing patients, especially when we're dealing with a lower CD4 counts. Unfortunately, LAM tests we do not have available in the kingdom yet. What about the other modalities that we have? I mean, the common modalities that we have, the BBD skin test and the IGRA. Comparatively, the two do badly in a patient with HIV, because a negative test would not exclude the latent tuberculosis because of the immunosuppression. And if you look at them less than 100, CD4 less than 100, almost universally everybody will be BBD negative. The current evidence suggests that maybe the ICRA or quantiferon test is relatively better, but yet it's not conclusive. And don't dream of having a reaction like this patient. This is only for immune normal person. That's not for HIV patients. Treatment of latent tuberculosis over hope, because we can prevent the development of active tuberculosis. We have the isoniazid. The INH plus rifabintine is not yet available in the kingdom. The rifabintine is not yet available. The rifampicin for 4 months is also available, but we know the drug-drug interaction with the tuberculosis treatment. Now, in the prevent TB studies, the rifabintine plus INH for 12 weeks was almost equivalent to 9 months of therapy with an INH and pyrazinamide. And the isoniazid really carried the advantage that you can use any antiretroviral therapy. When you go back to the rifampicin or rifampin-based regimen, you have to have a certain limitation with antiretroviral therapies. In 2019 March, there was this article nominating that 1 month of rifampicin and isoniazid is equivalent to 9 months of treatment with INH and pyridoxine. And in fact, that was true whether we have a lower CD4 count or even an early HIV infections. The good thing in this study, because of shorter durations, 97% was able to achieve treatment completion. In relation to the INH, because of the long therapy, there was only 90%. The cure rate or the incidence rate was almost the same in 2 arms. Now, the problem with this regimen is the burden of tablet. The rifabintine comes as 150 milligram. The INH we have here is only 100 milligram. So we're talking about another additional 13 or 14 tablets the patient has to take, especially when you use pyridoxine here, it has to be with a higher dose. So what about the treatment of the co-infection? The DHS guidelines stated that you look for the, if the infection is there, then you have to assess the CD4 count, and obviously if the CD4 count is low, you will start the treatment of antiretroviral within 2 weeks. If the CD4 count is more than 50, you will delay them for up to 8 weeks. And if you are dealing with a pregnant woman, you start as early as possible. And if you are dealing with a CNS infection that we tend to see, and that's a really big problem, because even if you start 8 weeks later or so, the mortality rate is still high. Which drug we can use in the guidelines for that? Again, the evaporins based. Really, this is a very difficult suggestion. If you go to the days of evaporins where you have a lot of problems with CNS, with suicidal attempt, with all the problems, then we are going back to the same because of tuberculosis and the drug-drug interaction with rifampicin. But it's still over a good help for those patients. The problem with it, the CNS side effect, the suicidal attempt, again, is a low genetic barrier regimen. Activity against certain genotypes of the HIV is a problem. Other alternative, we have an integrase-based regimen, and here we have 2. We have dolutegravir-based, and we have the raltegravir-based. And again, the dolutegravir or raltegravir, we have the double dose because of the rifampicin drug-drug interactions. Looking at the drug-drug interaction with antiretroviral therapy, rifampicin is an important part. But yet, because we have very few limitations on tuberculosis treatment, we still have to use rifampicin. And if you use rifampicin, our backbone here will be TDF and FTC or an abacavir and 3-TC. The questions regarding TAF use with rifampicin, I think it may change in the future. Still not yet recommended now, but we have a lot of pharmacokinetic studies that's saying that 25 milligrams BID of TAF may be giving adequate level, because the reduction with rifampicin was only 12% if you double the dose versus 24% reduction in TDF when using a single tablet. So it may come. So far it's not recommended. If you come to the NRTIs, evaporins is there, whether it is 400 or 600 milligram, both of them are acceptable with rifampicin. With rifampicin, you have to increase the dose. And with the integrase inhibitor, both of them, raltegravir as well as dolutegravir, can be used with doubling the dose. The dolutegravir data is there for doubling dose. What we cannot use is the medication that we used to. We cannot use, for example, a co-formulated tablet with cobicistat. We cannot use a bictegravir because the reduction is huge. We cannot use boosted BI because, again, the drug-drug interaction with rifampicin is very difficult. So I think we're really having a limited choices, but they are okay, and they can function for our patients. The drug level of dolutegravir with rifampicin, this study reflects if you double the dose, you are achieve almost the same dose you are having with 50 milligram OD without rifampicin. And I think the figures are very clear, showing that the drug level is the same with dolutegravir. So in our guidelines, stated that HIV is the strongest risk factor for TB reactivation, and the disease HIV is accelerated by concomitant TB infection. The tuberculous manifestations may differ in HIV-positive patient, and this is really an alarm for all the physicians taking care of TB and HIV. The symptoms may be masked with the severe immunosuppression. We recognize 5 millimeter as the positive cutoff. We use ICRA if there is the CD4 count is less than 350, though the availability is a problem. And again, if you have a patient with HIV, history of exposure to tuberculosis, even with a negative BBD skin test, even with a negative interferon, we still recommend to treat him for latent tuberculosis. INH and paradoxin is a recommended regimen, although it's very long because we do not have an access to rivabentine. What about if we have patients with the naive patients? Obviously, we will start an anti-TB with the usual first-line anti-tuberculous medication. Rifampicin will be included because rifampicin is not available in the majority of centers belonging to MOH, so rifampicin would be included. Unless from gene expert or from the side effect, you have to exclude it for other reason, not because of HIV concomitant. You assess the CD4 and you look at the site of the infection, and then you decide when to start your treatment. Obviously, you will delay for a tuberculous meningitis. Patients who have HIV positive already on ART therapy, we have to assess the CD4, and if they are suppressed virus with a CD4 count more than 200, we have to do only the treatment modifications. And here there is a problem, because if you have a patient on a regimen which is high genetic barrier regimen, like he is on the Ronavir Cobicistat regimen, probably 25% of our patients on this regimen, and now you are coming back to raltegravir-based regimen or tivavirine-based regimen, it's obviously there is a risk. And we know from switch study that moving from lebenavir, ritonavir to raltegravir was a failure. So here you need to have a drug that really have a high genetic barrier that you can resort to on the change of the medications. If the patient is not suppressed, this is another indication that really you have to look at your patients, find out what is the best therapy for him. So in the concomitant infection, priority of treatment goes for TB, first-line drugs. Paradoxin is essential. Duration, we do not go for 6 months, we go for 9 months. There are some studies have shown that more failure rate when you have with the treatment is less than 8 months durations. For the treatment of HIV, we evaluate the CD4, we look at the viral load and the site of TB, and then decide when to start. It is either 2 weeks or 2 months, and the medication we have is the basically either evavirins. We don't have an access to 400, so we go with 600, dolutegravir or raltegravir on double doses. And if you look at the data on the dolutegravir, it's really reassuring. The inspiring study looking at the dolutegravir in a patients that they have the inclusion criteria of more than 1,000 viral copy at entry. They have either pulmonary, pleural, or lymph node tuberculosis, and it is rifampicin sensitive. And the patients have, it is documented either by culture or gene expert, and the patient have been on rifampicin for the induction phase, and then you either randomize them to dolutegravir or evavirins for the duration of therapy of the rifampicin, and then you can come down with dolutegravir. And the primary endpoints was really the viral suppression of less than 50 copies at 24 and at 52 weeks. It is no surprise that we can achieve viral reduction faster with the dolutegravir integrase-based regimen-based versus the evavirins, but at 24 both were the same. And again, it's no surprise that the elevation of CD4 was higher among those who received dolutegravir than among those who received evavirins. I don't know whether that's good or bad in the situation of tuberculosis, but it is a finding. And if you look really at the outcome, dolutegravir was doing as good as evavirins, with the 88 versus 91 success rate of treatment at the 24 and 48 weeks. So to summarize on dolutegravir, it has to be a BID dosing. It can be used, and it can be used in treatment with a rifampicin-based regimen. IRIS, those who have seen TB and HIV, this is their main concern in a patient who's coming to you with tuberculosis, and then you start treatment, and then when you introduce antiretroviral, they run into more problems. It is, according to the definition, it is estimated to be between 8 to 40% of the patient, depending on how loose you are with the definition criteria. The predictors are so many, including, for example, the lower the CD4 count, the higher the chance. The rapidity of CD4 count recovery is another risk. Again, the viral loads and the virological suppression being very fast could be considered as a risk. And the severity of disease, especially the CNS infection, is really a big problem. The TB meningitis and the CNS tuberculoma, that's really a big problem. Now, most of the IRIS symptoms would develop within 3 months, And the steroid can improve symptoms. I'm concluding because I think my time is almost there. Among people with latent tuberculosis, HIV is the strongest known risk factors to progression to active tuberculosis. The TB is the leading cause of death and the main cause of admission in HIV-positive patient. We have TB preventive therapy that can reduce the activation of tuberculosis and prevent the infection. And we have to be more in using this, whether we have a positive test or not, because we are really having a problem with the baby skin test in patients with an advanced immune suppression. Timely introduction of an antiretroviral therapy with, depending upon the HIV status of the patients, the CD4 count of the patient, and the site of infection is the key. And the options we have are limited, but they are better than what we have the options from the tuberculosis treatment. So we still maintain the rifampicin in the anti-tuberculosis medication. Thank you very much.